Viral hepatitis is liver inflammation caused by a viral infection, and it can be either acute or chronic, and 5 important causes are hepatitis A, B, C, D, and E. Acute viral hepatitis lasts for less than 6 months, and the individual has nausea, vomiting, and right upper quadrant pain. Sometimes, if there's a high total bilirubin, it can lead to jaundice, pruritus, dark urine, and clay-colored stools. Now, chronic viral hepatitis lasts for more than 6 months, and the individual can sometimes be asymptomatic. Other times, chronic viral hepatitis can cause fever, fatigue, and loss of appetite, as well as extrahepatic symptoms like arthralgias and skin rashes. On the physical examination with acute hepatitis, there's typically hepatomegaly, but with chronic hepatitis, the liver may feel normal on palpation. And if there's cirrhosis, the lower margin of the liver can feel irregular. A diagnostic workup for viral hepatitis includes a CBC, AST, ALT, total bilirubin and unconjugated bilirubin, alkaline phosphatase, and PT, PTT, and INR. Thrombocytopenia, prolonged PT, and prolonged PTT, as well as an elevated INR, can be present in both acute and chronic hepatitis. In acute hepatitis, levels of AST and ALT are over 100 international units per liter, and sometimes the alkaline phosphatase and total bilirubin are elevated as well. If the total bilirubin is above 2 mg per deciliter, then an individual can appear jaundiced. With chronic hepatitis, elevation of AST and ALT persists for more than 6 months, but levels don't usually rise above 400 international units per liter. In addition, total bilirubin and alkaline phosphatase levels can also be elevated. During viral hepatitis, medications that are metabolized by the liver, like aspirin, or medications that can damage the liver, like acetaminophen, should be used with caution because they can further damage the liver. Okay, so let's start with hepatitis A, which only causes acute hepatitis. It's caused by contaminated food and water and often affects travelers. In hepatitis A, serum anti-hepatitis A virus IgM antibodies are elevated for about 6 weeks, and anti-hepatitis A IgG antibodies begin to rise a couple of weeks after IgM antibodies, and usually persist for life. So, if there are IgG antibodies and no IgM antibodies, that means that the person was vaccinated for hepatitis A, or had a prior infection and developed immunity. Hepatitis A usually resolves within a few weeks, and the main treatment is giving fluids in case of dehydration. Hepatitis A can be prevented by vaccinating children, as well as adults that are about to travel in countries with a high rate of hepatitis A infection. 2 doses of the vaccine are given 6 months apart. Next up is hepatitis E, which typically causes acute hepatitis, but can also cause chronic hepatitis in immunocompromised individuals. Like hepatitis A, it's also caused by contaminated food and water, but it can also be transmitted from mother to child during birth. Usually the symptoms are mild, but if it develops in pregnancy, it can be severe and lead to acute liver failure. In acute hepatitis E, anti-hepatitis E virus IgM are elevated for about 2 months, and IgG antibodies begin to rise around the same time as IgM antibodies. But they don't persist for more than a few years. HEV RNA, which is a marker of virus replication, is also checked in the stool, or in the serum, to confirm the infection, and levels are usually high. With chronic hepatitis E, HEV RNA is detected in the serum or in the stool for more than 6 months. Acute hepatitis E usually resolves within a few weeks, and the main treatment is giving fluids in case of dehydration. However, in cases of acute liver failure, a liver transplant may be needed. In immunocompromised individuals with chronic hepatitis E, treatment involves lowering the doses of immunosuppressants and giving ribavirin for 12 weeks. Next is hepatitis B, which can cause acute hepatitis and chronic hepatitis. It's caused by contact with blood, like sharing needles or syringes, and contact with body fluids, like unprotected sex, or can pass from mother to child during labor and delivery. Testing for hepatitis B requires sending serology. First, there's hepatitis B surface antigen and anti-HBs, which is the antibody to hepatitis B surface antigen. Usually, if one is positive, the other's negative, sort of like yin and yang. One exception is if an individual has never been exposed to the hepatitis B virus or vaccine in their life, in which case they're both negative. Another exception is when a person has actually cleared the hepatitis B infection, so the hepatitis B surface antigen is gone, but levels of anti-HBs still haven't risen high enough to be detected, so it appears to be negative, even though technically there's anti-HBs floating around. That's called the window period. But most of the time, if the hepatitis B surface antigen is positive and anti-HBs is negative, that means there's an acute or chronic hepatitis B infection. And if the hepatitis B surface antigen is negative and anti-HBs is positive, that means an individual has been immunized or has recovered from a natural infection. Either way, they're protected from hepatitis B. After looking at hepatitis B surface antigen and anti-HBs, the next step is to look at antibodies made against HBsAg, which is hepatitis B core antigen. There's IgM anti-HBc, which is IgM antibodies against hepatitis B core antigen, and there's total anti-HBc, which is total antibodies against hepatitis B core antigen, mostly made up of IgG antibodies. Neither of these rises with the vaccine. Now, in acute hepatitis, both the IgM anti-HBc and the total anti-HBc become positive. But as weeks go by, the IgM anti-HBc becomes negative, while the total anti-HBc remains positive. That happens if the person clears the hepatitis B infection, or if there's chronic hepatitis. So it really only tells you about the passage of time. Finally, there's HBeAg, which is hepatitis B antigen. Try saying that 3 times quickly. If it's positive, then the virus is actively replicating, and that means a person is highly infectious. If it's negative, it could be because the virus isn't actively replicating, or because there's no virus around at all. There's also HBV DNA PCR, or hepatitis B virus DNA PCR, that can be sent, and it usually mirrors HBeAg, but gives even more information. High HBV DNA levels mean that the virus is actively replicating and highly infectious. Low HBV DNA levels means that the virus is around but not actively replicating, and having no detectable HBV DNA means that there's no virus. Now let's put these hepatitis B serological markers into a table and go through some scenarios. In someone that's susceptible to hepatitis B and hasn't been immunized, hepatitis B surface antigen, anti-HBs, IgM anti-HBc, total anti-HBc, hepatitis B antigen, and HBV DNA are all negative. In someone that's immunized, anti-HBs becomes positive, while hepatitis B surface antigen is negative, and the rest will remain negative as well. Now, in someone with acute hepatitis B infection, hepatitis B surface antigen is positive, and anti-HBs is negative. And because it's acute, both IgM anti-HBc and total anti-HBc are positive. Typically, the virus is actively replicating at this stage, so hepatitis B antigen and HBV DNA levels are elevated as well. After a number of weeks later, IgM anti-HBc becomes negative, while total anti-HBc remains positive for life. Finally, if the infection gets brought under control to the point where the virus is no longer actively replicating, then the hepatitis B antigen becomes negative, and the HBV DNA levels fall, and anti-HBe antibodies appear. Finally, there's chronic hepatitis B infection, which has a few phases. The immune-tolerant phase usually develops in individuals that are infected during birth, and it can last a few decades. There's minimal liver inflammation, so the ALT and AST may be normal or slightly elevated. During this phase, hepatitis B surface antigen is positive, and anti-HBs is negative. And because it's chronic, IgM anti-HBc is negative, while total anti-HBc remains positive. Typically, the virus is actively replicating at this stage, so hepatitis B e antigen and HBV DNA levels are elevated as well. Then there's the immune active phase with positive hepatitis B e antigen, which is where there's more liver inflammation, so ALT and AST are elevated. And, as a result, the HBV DNA levels start to fall a bit. But in other ways, the labs are the same. Hepatitis B surface antigen is positive, anti-HBs is negative, IgM anti-HBc is negative, and total anti-HBc remains positive. And the virus is still actively replicating, so hepatitis B e antigen is positive. Next, there's immune active phase with negative hepatitis B e antigen, which is when the ALT and AST remain elevated, but the HBV DNA levels fall even lower, and the hepatitis B e antigen becomes negative, meaning that the individual is less infectious. In other ways, the labs are the same. Hepatitis B surface antigen is positive, anti-HBs is negative, IgM anti-HBc is negative, and total anti-HBc remains positive. Next, there's the inactive chronic HBV phase, which is when the ALT and AST normalize and HBV DNA levels fall even lower, and the hepatitis B e antigen remains negative. And as before, the other labs are the same. Hepatitis B surface antigen is positive, anti-HBs is negative, IgM anti-HBc is negative, and total anti-HBc remains positive. And finally, when someone successfully clears the infection, anti-HBs becomes positive, while hepatitis B surface antigen is negative. Total anti-HBc remains positive as well, and the IgM anti-HBc, hepatitis B e antigen, and HBV DNA are all negative. Now, an important complication of chronic hepatitis B is cirrhosis, which can lead to hepatocellular carcinoma. In fact, high titers of HVA DNA and hepatitis B surface antigen correlate with a higher likelihood of developing cirrhosis. So, every 6 months, an ultrasound is done, and alpha-fetoprotein levels can also be checked to monitor for possible tumors. Treatment of acute hepatitis B is mainly supportive, like giving fluids and antiemetic medications like metoclopramide. Treatment of chronic hepatitis B largely depends on the HBV DNA and ALT levels and whether or not there's cirrhosis. Individuals without cirrhosis that have HBV DNA levels above 20,000 international units, or IU, per milliliter, and ALT levels above 2 times the upper limit of normal are started on treatment. If the HBV DNA levels are above 20,000 IU per milliliter, but ALT is below the 2 times upper limit cutoff, then ALT levels are monitored every 3 to 6 months, and if it ever reaches that cutoff, then treatment is started. If HBV DNA levels are between 2,000 and 20,000 IU, and levels of ALT are under 2 times the upper limit of normal, then the labs are monitored every 1 to 3 months. If HBV DNA remains between 2,000 and 20,000 international units per milliliter for 6 months, then treatment is started. If the HBV DNA levels are below 2,000 IU, and levels of ALT are under 2 times the upper limit of normal, then labs are monitored every 3 to 6 months. If ALT levels rise above 2 times the upper limit of normal, then treatment is started. Treatment options include pegylated interferon, or PEG-IFN. which is an antiviral agent that's administered by subcutaneous injection once a week for 48 weeks. Other options include nucleoside or nucleotide analogs, like entecavir or tenofovir, which are given orally until hepatitis B e antigen becomes negative, and then for 1 more year after that. If hepatitis B e antigen was initially negative, and HBV DNA levels rise above 2000 IU, and ALT levels rise above 2 times the upper limit of normal, then the treatment is restarted to prevent hepatitis B e antigen from becoming positive. This time, PEG-IFN is used for a year, and the nucleoside or nucleotide analogs are used for several years. On to treatment for chronic hepatitis B with cirrhosis. First, in individuals with compensated cirrhosis, when there's no jaundice or ascites, and HBV DNA is above 2,000 international units per milliliter, entecavir or tenofovir are given indefinitely. In individuals with compensated cirrhosis and HBV DNA levels below 2,000 international units per milliliter, entecavir or tenofovir is given only if ALT levels are elevated. And in individuals with compensated cirrhosis, if HBV DNA levels are undetectable, then no treatment is started. In individuals with decompensated cirrhosis, where there is jaundice or ascites, entecavir is started regardless of ALT and HBV DNA levels. In individuals with decompensated cirrhosis and undetectable levels of HBV DNA, a liver transplant may be done. Prevention of HBV infection is done by vaccination in infants and in adults that are not immune to HBV infection and have a high risk for developing it, such as a healthcare professional, injection drug users, and immunocompromised individuals. In newborns, 3 doses are given, the first shortly after birth, the next at 1 month of age, and the last at 6 months. In adults, 2 doses are given, 1 month apart. Okay, next is hepatitis D, which can cause acute or chronic hepatitis. It's caused by hepatitis D virus, or HDV, which is a defective virus that needs HBV to cause an infection, because hepatitis B surface antigens make up the outer envelope within which the HDV genome resides. So, like hepatitis B, hepatitis D is transmitted through blood and body fluids. Now, acute hepatitis D can be due to a co-infection, meaning that both B and D viruses infect the individual at the same time, or a superinfection, meaning that hepatitis D infection occurs after there's a pre-existing chronic hepatitis B infection. Oftentimes, an acute hepatitis D infection doesn't get cleared, and it turns into a chronic hepatitis D infection. Testing for hepatitis D requires confirmation of hepatitis B infection, as well as testing for HDV IgM, which is IgM antibodies against hepatitis D, total HDV antibodies, which is total antibodies against hepatitis D, mostly made up of IgG antibodies, serum HDV RNA, and hepatitis D antigen, which usually remains positive only briefly. In acute hepatitis D co-infection or superinfection, HDV IgM is elevated, and total HDV antibodies may be negative if the IgG levels haven't climbed very high. HDV RNA is usually positive, and hepatitis D antigen may be positive or negative because it disappears so quickly. Whereas with chronic HDV infection, HDV IgM is negative, total HDV antibodies are positive, HDV RNA is positive, and hepatitis D antigen is negative. Treatment of hepatitis D is initiated in individuals that have elevated HDV RNA levels and elevated AST and ALT levels. Pegylated interferon alpha 2A or alpha 2B is given once a week for 12 months. Prevention of hepatitis D is accomplished through hepatitis B vaccination. Next is hepatitis C, which is caused by hepatitis C virus and can cause acute or chronic hepatitis. It's caused by contact with blood, like sharing needles or syringes, and contact with body fluids, like unprotected sex and during passing from mother to child during labor and delivery. Hepatitis C can cause extrahepatic manifestations, like cryoglobulinemia, which is where the blood viscosity is high and causes headaches and confusion, membranoproliferative glomerulonephritis, and dermatologic conditions, such as porphyria cutanea tarda, which can cause erosions and blisters. The first step in diagnosis is to look for anti-HCV IgG antibodies. If they're positive, then the next step is to send HCV RNA PCR. If HCV RNA is not detected, it likely means that it was a past infection that has now cleared. If HCV RNA is detected, then the individual has a hepatitis C infection. If titers HCV RNA remain elevated for more than 6 months, then it's considered a chronic hepatitis C infection. Otherwise, it's considered an acute hepatitis C infection. Once a diagnosis is established, it's helpful to calculate the APRI score, which is the AST to platelet ratio index. It's calculated by dividing the individual's AST level by the normal value of AST, and then dividing by the platelet count and multiplying by 100. This estimates the degree of liver fibrosis. If the score is below 0.5, there's minimal fibrosis. Between 0.5 and 1.5 is in between, and above 1.5 means that there's significant fibrosis. In individuals with cirrhosis, there's a high risk for developing hepatocellular carcinoma. So, an ultrasound is done every 6 months, and alpha-fetoprotein levels can also be checked to monitor for possible tumors. Treatment of hepatitis C in individuals without cirrhosis can be initiated using either sofosbuvir coupled with either velpatasvir or daclazivir for 12 weeks, or by using glecaprevir and pibrentasvir for 8 weeks. In individuals with hepatitis C with compensated cirrhosis, sofosbuvir and velpatasvir can be used for 12 weeks, or glecaprevir and pibrentasvir can be given for 12 weeks, or sofosbuvir and daclazivir can be given for 24 weeks. In individuals with decompensated cirrhosis, sofosbuvir plus velpatasvir for 24 weeks, or sofosbuvir plus daclazivir for 12 weeks can be used. In some cases, may require liver transplantation. Alright, as a quick recap. Hepatitis A causes acute hepatitis, and anti-hepatitis A virus IgM antibodies rise, and anti-hepatitis A IgG antibodies persist for life. Treatment is supportive. Hepatitis E causes acute hepatitis, including fulminant hepatitis in pregnant women, but it can also cause chronic hepatitis in immunocompromised individuals. With acute hepatitis E, anti-hepatitis E virus IgM and HEV RNA are positive and treatment is supportive. With chronic hepatitis E, HEV RNA is detected in the stool or serum for more than 6 months, and ribavirin can be used. Acute hepatitis B shows positive hepatitis B surface antigen, hepatitis B E antigen, and IgM anti-HBC antibodies, along with high levels of HBV DNA, ALT, and AST. Chronic hepatitis B in the immune-tolerant phase shows positive hepatitis B surface antigen, positive total anti-HBC, positive hepatitis B E antigen, and high levels of HBV DNA. In the immune-active phase, the hepatitis B E antigen remains positive, but HBV DNA levels are lower, while ALT and AST levels rise. Then there's the immune-active phase, with negative hepatitis B E antigen, and the inactive chronic HBV phase, where HBV DNA is low and AST and ALT levels are normal. Treatment of acute hepatitis B is supportive, while chronic hepatitis B can be treated with PEG-IFN, entecavir, and tenofovir. Hepatitis D can cause acute or chronic hepatitis and needs hepatitis B virus in order to cause an infection. With a co-infection and superinfection, there's positive HDV RNA and IgM anti-HDV antibodies. With chronic hepatitis D, HDV RNA is positive and hepatitis D antigen is negative. Treatment includes PEG-IFN for 12 months. Hepatitis C can be acute or chronic, and serology shows positive anti-HCV antibodies and elevated levels of HCV RNA. In individuals without cirrhosis or with compensated cirrhosis, treatment includes sulfosbuvir coupled with vilpadisvir or dacladisvir, or glecaprevir plus pibrentasvir. In individuals with decompensated cirrhosis, sofosbuvir plus either vilpadisvir and dacladisvir is used.